So in a normal functioning heart, when you are auscultating with your stethoscope, what sounds do you hear? Well, if you remember back to your clinical foundations, we hear S1 and S2 heart sounds in the normal functioning heart. So here we can see S1, and then we can see this A2 and P2, and this represents S2, and we'll discuss a little bit more about why there's a distinction of A2 and P2 just here in a little bit. But first, what makes the S1 and S2 sound? What is it that we're actually hearing with our stethoscope? Well, remember, it all has to do with blood flow against a closed valve. When blood is flowing quickly through the heart, and when it hits a closed valve, it makes a sound that we can appreciate with our stethoscope. So the S1 sound is created by blood basically smashing into the mitral and tricuspid valves. This heart sound represents the onset of systole. The S2 sound is the sound that is created when blood flows against the closed aortic and pulmonic valves, which is represented by A2, which is the aortic valve, and P2, which is the pulmonic valve, that both combine to create the S2 heart sound. So when you think about it, we hear two heart sounds, S1 and S2, but really there are four valves that are closing. So we hear two heart sounds for four valves. And the reason you only hear two heart sounds in general is because the valves close at pretty much the exact same time. So when the blood flows up against the closed valve and makes the noise that we hear on our stethoscope, it's pretty much occurring at the same time. So you only hear one sound. However, for S2, it's a little more complicated, and we can actually hear both. If you really listen closely, you can actually hear two components of the S2 heart sound, representing the aortic closure and representing the pulmonic closure. And this brings up a concept of what is called normal splitting or physiologic splitting. The S2 heart sound can be split into distinct aortic and pulmonic sounds. This splitting occurs as a result of respiration. There are variations in respiration, specifically in inspiration, that causes the A2 and P2 heart sounds to split. So this graph here, or this line, just is represented by time here, essentially on an x-axis, going this way between S1 and S2. And we can see that during periods of expiration, the A2 and P2 heart sounds are essentially occurring at the same time. And then during inspiration, we see this increase in time between A2 and P2, and that is what is called physiologic splitting. So during inspiration, we see physiologic splitting of the S2 heart sound. That is the main concept. So why does this happen? Why does inspiration split the S2 into aortic and pulmonic components? Why is it more distinct, and why can we hear it or appreciate it when we listen to it during auscultation? Well, the reason is the pulmonic valve actually closes later than the aortic valve, so we can hear the distinct sound. It shuts later because there is an increase in end diastolic volume in the right ventricle after inspiration. So let's think about that for a second. Why does this happen? So there are two things that occur on inspiration that increase the end diastolic volume in the right ventricle. With inspiration, think about the anatomical and cardiophysiologic changes we see in our thorax. So when we inspire, our chest wall expands, the intrathoracic volume increases, which results in a more negative intrathoracic pressure. So as we increase the volume, we have a more negative intrathoracic pressure. This is really the key here. When we have a negative intrathoracic pressure, we actually see an increase in venous return. This is an important concept. We see an increase in venous return from the extremities, from the abdomen, from the head and neck, through the SVC, through the inferior vena cava, and into the right atrium, and subsequently right ventricle. As such, we see an increase in end diastolic volume. If you think about it simply, the chest cavity during inspiration is bigger, there's increase in volume, so there's more space that needs to be filled up. And what fills up that space? It's blood. The blood fills that volume that we create during inspiration and increases the blood flow back to your right ventricle. So as such, as we've discussed, we have more blood in the right ventricle, increase in end diastolic volume during inspiration. So that means that the pulmonic valve really needs to stay open longer so that this extra blood can be pushed out appropriately. So we see this increase in blood shot out from the right ventricle and into the pulmonary vasculature. And remember, the vessels in the lung really have no problem storing this increased blood because there's increased compliance in the lung, during inspiration. And ultimately, that pulmonic valve closes a little bit later than the aortic valve, and so we see this splitting. So we literally hear the pulmonic valve closing after the aortic valve. So this really is the physiologic basis of normal splitting. And the fundamental concept is that when you inspire, there's more blood in the right ventricle because of the increased compliance of the thorax and increased intrathoracic volume filled by more blood from the extremities, resulting in a longer period of time it takes for the right ventricle to sufficiently empty before the pulmonic valve closes, creating that P2 sound. So there are several abnormalities or changes in this physiologic splitting that represent certain pathologic conditions. The first one we're going to talk about is what's called wide splitting. Wide splitting means that the gap between the aortic and pulmonary component of S2, or A2 and P2, is wider. It is wider or longer in inspiration than in expiration. There's a greater change, or the delta between A2 and P2 is greater than normal. At the end of the day, the fundamental concept that results in wide splitting is that there is a delayed closure of the pulmonic valve. The pulmonic valve closes later than the aortic valve by a greater distance or a greater time. And really, the pathologies that result in excessively prolonged closure of the pulmonic valve is anything that causes delayed contraction of the right ventricle or any sort of pathology to the right ventricle or pulmonic valve itself. So for instance, in a right bundle branch block, we see a delayed depolarization of the right ventricle, resulting in delayed contraction of the right ventricle, causing a delayed closure of the pulmonic valve. It all sort of comes together nicely in this right bundle branch block. When you have a pulmonic valve stenosis, or when the pulmonic valve is narrowed or stenotic, then it takes longer for the right ventricle to push the requisite volume through the pulmonic valve, and that extra little time is denoted by a wide split or a delayed closure of the pulmonic valve and a delayed P2. So the two key ones I want you to know for your exam are right bundle branch block and pulmonic valve stenosis as the pathologies that result in wide splitting. So the next abnormality we're going to go over is what is called fixed splitting. Fixed splitting is a concept that describes a situation when we have wide splitting. So there is wide splitting, it's greater than normal. This period between A2 and P2 is greater than normal. And no matter what phase of respiration you're in, whether you're inspiring or expiring, the splitting or the wide splitting remains fixed. It doesn't change between respiratory variation, which is a key difference between normal and wide splitting. In fixed splitting, we see that the split between A2 and P2, this time here, is fixed between inspiration and expiration. There is minimal or no change between this splitting between aortic and pulmonic valve closure in expiration or inspiration. So we remember back, in inspiration, we increase our end diastolic volume. The right ventricle subsequently requires longer period of time to eject all that blood from the right ventricle. The pulmonary valve closes later than the aortic valve, causing this normal physiologic splitting. But in cases of fixed splitting, or in pathologies that cause this fixed splitting, we see no significant change or variation in expiration or inspiration phase. So, you can say that this wide splitting is fixed in time. It's fixed in time. It will not change no matter what phase of respiration you're in, whether you're expiring or inspiring. So what causes this? Why do we see this, and what pathologies are associated with fixed splitting? Well, the most common pathology that causes fixed splitting is an atrial septal defect, or a defect in the septa splitting the right atrium and left atrium. You can see here. So, in an atrial septal defect, blood is shunted from the left atrium, or the atrium of higher pressure, to the right atrium, or the atrium of lower pressure. The blood flows from the left atrium into the right atrium and then down into the right ventricle. So we actually see an increase in the volume of the right ventricle no matter what the change to intrathoracic pressure is. No matter if it's inspiring or expiring, there is going to be always an increase in right ventricular pressure because blood is being shunted inappropriately from the left atrium to the right atrium. The shunt will be maintained, and we will see the split no matter what period of respiratory phase the patient is in. So once again, we see an increase in blood traveling across the pulmonic valve, resulting in a delayed closure of P2. This is what we call fixed splitting. And the atrial septal defect is the most high-yield example of fixed splitting that you may see on your Step 1 exam. Final abnormality in splitting that we're going to discuss is called paradoxical splitting. Let's look at the normal splitting and then paradoxical splitting and compare the two to really understand what's going on here. So, in the normal physiologic splitting, we see S1 followed by A2 preceding P2 to compose the S2 heart sound. In paradoxical splitting, we can see that this has reversed. It has changed. It is paradoxical. The pulmonic closure occurs before the aortic closure, so we can see P2 precedes A2. So can you think of some reasons why we would see this reversal, where we would see the pulmonic component or the pulmonic valve close before the aortic valve? What do you think is going on physiologically that will result in the aortic valve closing later than it's supposed to? Well, if we think about it, similar to the way normal physiologic splitting occurs, that there's an increase in volume in the right ventricle causing the delayed pulmonic closure. In this scenario, what we're seeing is there's an increase in left ventricular volume such that the aortic valve closes later. There's an increase in volume that needs to be pushed out, or blood takes longer to exit to the left ventricle because of some anatomic abnormality. So similar to what caused the wide splitting, something like a left bundle branch block in which we see delayed depolarization of the left ventricle and delayed ventricular contraction, taking longer for all the blood to pass the aortic valve and cause delayed closure of the aortic valve, represented here as A2. That would cause a paradoxical splitting of the S2 heart sound. Another pathology that would cause this sort of paradoxical splitting is aortic valve stenosis. Aortic valve stenosis. We actually have a stenotic or narrowed aortic valve, meaning that it takes longer for that 100 cc's or 200 cc's of end diastolic volume to pass through into the aorta before the aortic valve closes. So at the end of the day, we have this stenotic aortic valve. We see delayed ejection of left ventricular volume, resulting in a delayed closure of the aortic valve. This is causing the paradoxical splitting. So we see a stenotic or narrowed valve. Blood is trying to leave from the aortic outflow tract from the left ventricle. It's blocked, it's slowed from the stenotic valve, and therefore the aortic valve closes later than the pulmonic valve, and we see a paradoxical splitting. And we can see that the inspiration variation, or the variation we see in inspiration, holds true in this paradoxical splitting. As we inspire, we increase our right ventricular volume. The pulmonic valve closes later, and so we actually see it shift to the right here, which reminds us of normal physiologic splitting. So when we inspire, we decrease the splitting between A2 and P2. The split is smaller because we're increasing the volume in the right ventricle, so the P2 occurs later. During expiration, we see that the splitting is exacerbated. It's wider. So this is sort of a concept to remember, that paradoxically, A2 occurs after P2, but the normal physiologic splitting still occurs in this situation where pulmonic valve closure is later or delayed during the inspiratory phase because of the increase in intrathoracic or in right ventricular volume.